in tumors and how you can modulate them to improve anti-cancer therapy.
Thank you for the introduction and the invitation to be here. Good morning, ladies and gentlemen. So my name is Stylianopoulos and I'm a lecturer of mechanical engineering at the University of Cyprus. So we all agree that effective delivery of nanoparticle formulations to solid tumors utilizing the EPR effect requires a functional vascular network. Now the problem that we have in many tumors is that the tumor grows in the confined space of the host tissue. So this generates mechanical forces that can compress and eventually collapse intratumoral blood vessels, and this will reduce tumor perfusion. And we have a nice movie here where you see this phenomenon. So this is the vascular network, and we see the cancer cells. We don't see the extracellular matrix here or the stroma cells. The cells proliferate in this confined space. At some point, they start to touch the vessel wall. They compress the vessel wall. The fluid pressure, the vascular pressure cannot resist this solid stress. We have the deformation of the vessel, and finally we have the collapse of the vessel. The tumor, in this region of the tumor, becomes hypoxic because we don't have supply of oxygen, and then also reduces the perfusion, and it results in the formation of necrotic tissue. So it's easy to understand that in these types of hypovascular and hypoperfused tumors, like the pancreatic ductal adenocarcinomas or a subset of breast tumors, it's of secondary importance to talk about the EPR effect, and also we cannot apply vascular normalization treatment because these tumors, they don't have a functional vascular network. So to show you some evidence about the mechanical force in tumors, what we see here is a intramuscular myxoma, which was excised from the right lip of a 62-year-old woman at Massachusetts General Hospital. So after the surgeon excised the tumor, I made a cut, as you see here, along the longest axis, 80% to the thickness of the tumor. And as we see that the tumor relaxes as a result of the relaxation of the stress inside the tumor. So we see that the interior of the tumor swells, which implies that the interior is in compression, while the periphery of the tumor at the point of the cut retracts, which is typical of relaxation of tensile stresses. So it's easy with this to measure the tumor opening with a caliber and to quantify then with mathematical modeling the amount of these solid stresses. And also there is clinical evidence of vessel compression. So what we see here is histology of the human breast tumor, where this arrow shows the position of the vessel, and we see that the lumen is deformed. It has this elliptical shape, while in this case the brown color shows the endothelial lining, and we don't see the lumen because the vessel is collapsed. So in the first case here we have compromised flow, while in the second case we have no flow, no perfusion at all. And this is a histology image of a human pancreatic ductal adenocarcinoma, where with the pink color we see it's a highly desmoplastic tumor. It's only 5 to 10% of pancreatic cancers consist of cancer cells. The rest of it is stroma cells and extracellular matrix. And again, with these two arrows, we see the position of two collapsed vessels. And it's estimated that in pancreatic ductal adenocarcinomas, the 80% of the vessels are collapsed, and only the 20% of the vessels are functional, which also suggests why we cannot effectively deliver drugs to this type of cancer. But despite the fact that the tumors are not well vascularized, they still grow, they metastasize, people die from this. So the basic idea that we have is to re-engineer the cancer, to re-engineer the microenvironment of these solid tumors, of these highly desmoplastic tumors, in order to alleviate this mechanical stress and to decompress the blood vessels. So we expect that the compression of vessels will improve perfusion, and improved perfusion will enhance drug delivery, and then enhanced drug delivery will result in increased survival, will get better outcomes. And this is the basic idea in these two figures. This figure shows the microenvironment of a pancreatic ductal adenocarcinoma, where cancer cells form these nodules, and they're surrounded by collagen fibers. We have the cancer-associated fibroblasts, and these are hyaluronic acid. And we see also a compressed vessel. So the idea is how we can actually modify the microenvironment in tumors in order to get something like this to alleviate the stresses and the vessels to become functional again. And here the work that I have done so far. So the first study that I did was to identify the constituents of the tumor microenvironment that contribute to the generation of these mechanical stresses, mechanical forces in tumors. And what I did was to measure the stress levels at different tumor types. MU89 is a melanoma, E0771 and 41 are breast tumors. And I selectively depleted one of the components of the tumor microenvironment at each time. So the first time I depleted only cancer cells, and we see here the stress levels go down. The second time I deplete selectively stroma cells, and we get the same effect. The third time I depleted extracellular matrix, and again we see that stresses goes down. So based on this data, I decided to target stroma cells. So we depleted pharmacologically the stroma cells of two types of pancreatic cancers, AKN4.4 and KPN2, and we use a drug which hasn't reached the market yet. It's called saridegib. It's an inhibitor of the sonic Hedgehog pathway. So what we see here is that after administration of this drug, solid stresses goes down in both tumor types. The plus sign shows the treated group, the minus sign shows the control group. And we see that vessel diameter goes up. And we see that it goes up from 10 to 13 microns. And even this small increase in the diameter of the vessel, because from principles of fluid mechanics, we get a 47% increase in the fraction of perfused vessels without affecting the vascular density at all. So what this tells us is that this drug, the only thing that it does is to open and make functional vessels that were compressed, that they were not functional at all. So the next step was instead of using a drug which hasn't reached the market yet, to use a drug to repurpose a commercially available drug that someone can get it from the pharmacy shop, from the market. I had a supportive role in this Nature Communication study. I did have a leading role as in the previous study. So what we did here was to use losartan. Losartan, the commercial name is Cosar. It's made by Merck. The experiments were done at the research group of Rakesh Jain at Harvard Medical School. And losartan is an angiotensin receptor blocker. So what it does is it controls the blood pressure. It's an antihypertensive drug, and millions of people use this drug worldwide. It's safe and well tolerated. So we repurpose losartan, and we see here two intravital microscopy images of the same tumor, of the same site, at two different time points before and after treatment. With the blue color shows the matrix, and with the green color shows the vessels. So we have a lot of matrix, we don't have functional vessels. After treatment with losartan, we see that the matrix goes down, the collagen and hyaluronic acid goes down, and where there was matrix, now we see functional vessels that appear again. So we conclude that losartan has the ability to improve perfusion, but how perfusion is related to drug delivery and overall efficacy, which is what clinicians care about. So what we did here was a tumor growth study where we use two breast tumor cell lines, EO771 and 41, and this is a pancreatic cancer cell line. And the tumors were separated in 4 groups. The one group was treated with only saline, the control. The second group was treated only with losartan. The third group with only chemotherapy. And the last group with losartan plus chemotherapy. And we see with the blue color here that in both 3 cases, the combined treatment of an agent that re-engineers, modifies the tumor microenvironment, and along with chemotherapy, which actually kills the cancer cells, improves the overall survival. It's also very interesting to see that in this case, where we have pancreatic cancers, chemotherapy alone, the red color, doesn't do any benefit. But when it's combined with a drug which modulates, normalizes the microenvironment of the tumor, we see benefit. So a phase 2 clinical trial with the use of this drug losartan with chemotherapy is now ongoing at Massachusetts General Hospital, where they try this technique this strategy in humans. This is a new strategy which we refer to as a stress alleviation treatment. It's actually a tumor normalization strategy compared to the vascular normalization strategy. And we wait to see the results. So with this grant, with this idea, I submitted last year an ERC starting grant. at the European Research Council, which got funded. My grant was started 6 months ago. And I established the Cancer Biophysics Laboratory at the University of Cyprus, where the goal of our laboratory is to combine mathematical modeling with in vivo experiments in order to further elucidate this interaction, the correlation between the mechanics and the pathology of cancer, which is something that I refer to as the mechanopathology. And the optimal goal is to improve drug delivery and treatment efficacy. And in our lab, we do both mathematical modeling experiments. I'm a chemical engineer by training. I was trained to be a mathematical modeler, and then at Rakesh Jain's lab, I did all the experiments. So we develop mathematical models in order to understand better the tumor microenvironment and the generation of physical forces, and also we perform simulations to study the delivery of drugs, pharmacodynamic, pharmacokinetic studies to find desired rules for optimal cancer therapeutics. And also we perform the corresponding experiments to validate our models. Like, for example, we perform in vivo studies mice being tumors to study drug delivery, to apply strategies like normalization of vascular normalization. We can do this, or normalization of the tumor microenvironment with stress alleviation treatment, to measure the mechanical properties of tumors, interstitial fluid pressure, perfusion, and also in collaboration with other colleagues at the University of Cyprus, we have access to ultrasound-based techniques for imaging, perfusion, sonography, and so on. So some tips about the preparation of my ERC starter grant. I have found useful these 3 points. The first is when is the right time for me to submit my proposal. I moved to Cyprus in 2010. I applied in 2012. The reason was that I just decided to check what is the HCDEX citation, publication number, this quantitative data for the quality of a researcher, of research that have awarded this grant in the past. So when I found out that it was above the average of the people who were awarded this grant, I decided to apply. This was the right time for me. The second question is what panel and subcategory to choose for the proposal. Many people might think that my proposal went to the life science panel, which is wrong. So I initially was planning to apply to the life sciences, but in my proposal I have mechanics, I have mathematical modeling. So what I did was to visit the ERC's webpage, and I found projects that were funded the previous years. And using some keywords, I identified projects of the same area as mine in the area of biomechanics, area of drug delivery. So I decided to apply to the physical science and engineering panel. The third point is how we can write a successful proposal, which for someone who doesn't have any experience about ERC grants, it's very important. So what I did was to talk to colleagues of mine at the University of Cyprus who had awarded either a starting or an advanced grant before. And they helped me a lot, not only how to write the proposal, but in the second stage, how to prepare for the interview. And with this, I would like to close acknowledging my research lab, which most of these people are supported by my ERC grant, and some of them are supported by other grants that I participate from the FP7 framework. And also the experiments that I saw you were performed at the research group of Rakesh Jain at Harvard Medical School, but now we have all the technology and know-how to do these experiments independently at the University of Cyprus. I would like to thank you for your attention. I'm happy to take any questions.
Thank you very much. Questions?
Okay, sorry to bother again. So you reduce the collagen, right? What happens in the body out of the tumor?
So when we did the study with losartan, the major effect, since we give a drug that reduces blood pressure, is to check the blood pressure in mice. So we found that the dose that we use in order to open the vessels, it's lower than the dose that someone will use with losartan in order to reduce blood pressure. It didn't have any effect to blood pressure. And the idea is not like we want to deplete collagen at all. The idea is to deplete as much collagen as it's required in order to open the vessels. And I show you here that even a small increase in the vessel diameter for 3 microns from 10 to 13 can increase the perfusion by 47%. So I don't advocate that we're going to deplete all collagen, which of course will affect normal tissue. But we have to see, to make a study for the drugs that we use, the dose that we gave for losartan, or the drugs that I use for my ERC grant, which is different than losartan. We have a pilot study to try different doses and see what's the minimum dose that alleviates the stresses and so on.
Patrick?
Yes, very interesting talk. Now, if you are decreasing the collagen, the extracellular matrix, and you are increasing the tumor perfusion, there is a risk also that you will increase the spread of the metastasis. So how do you manage that?
So I agree with you that there are studies which show that if you have improved perfusion, you have improved metastasis. So we don't advocate that perfusion will improve the treatment. But we say that combined treatment of improved perfusion with chemotherapy will improve the treatment of chemotherapy. That's why we also use the chemotherapy in order to kill the cells. Now, if this will cause metastasis or not, with the treatment, with the study with losartan, it didn't cause metastasis. And this is something that, for my study here with the other drugs that I'm going that I'm working on, it's one of the parameters that we take into account we want to study. I think it's a dose effect, and it goes back to the previous question, that how much we want to improve perfusion. So it's like an optimization.
Okay.
Is there any retrospective data on losartan use in cancer patients in combination with chemo that you can look back at?
Yeah, there are many retrospective studies where people, there were cancer patients who were also suffering from high blood pressure, so they were taking losartan, and at the same time they had to take chemotherapy, and they found out that these patients were better response. And yeah, these studies show that these patients had improved efficacy. The treatment had improved efficacy in these patients because of the use of losartan. And this is one of the other main reasons and major reasons that this phase 2 trial initiated at Mass General Hospital.
Last one up there.
I have two short questions. First, by looking at tumors, human tumors in the pathology, did you correlate the degree of tumor dedifferentiation with the degree of intra-tumor pressure? Because I think this would be important for using this as a parameter for modeling. And second, this drug, Zare-Degib, is it already intended to clinical investigate for non-neoplastic diseases which are associated with pathological ECM deposition, like kidney fibrosis, for instance?
So for the first part, we measure fluid pressure, interstitial fluid pressure, and if you decrease the external matrix, then you increase the hydraulic conductivity of the tumor interstitial space, and fluid pressure goes down because the fluid can more easily travel inside the tumor. We didn't try to correlate the grade of the tumor and with the fluid pressure. For the second question, I'm focused on cancer right now, but of course, losartan, I guess I'm not a clinician, I don't know the area of liver fibrosis, but if the mechanisms are the same, and over there you want also to improve perfusion, depleting fibers, collagen fibers is also something that can improve perfusion. And I think that people have tried to use losartan for tuberculosis, which is similar.
I think the question wasn't the other drug, but maybe you guys can meet after the session, because we really have to move on. No problem. So thank you again.
Yeah, thank you. Thank you.
And then we go to the last talk of this session.